Hi everyone, my name's Dr. Brendan Davies. I'm a consultant neurologist at the University Hospital of the North Midlands in Stoke-on-Trent, and I'm a medical trustee for the Migraine Trust. I just first of all like to thank Ria Bowler for outlining something around vestibular migraine, and we'll answer some questions afterwards. I'd also like to thank all of you for giving up your Saturday mornings and coming to listen to us. I hope it's useful for everyone. What I'm going to do is I'm going to talk about the new therapies that are coming through for migraine, and I've entitled this MABs, TABs and JABs just because of the fact that that's pretty much what it is. I'm going to try and cover the following. I've only got about 20 minutes, 30 minutes, so it's going to be a bit of a quick run through, and I'm going to talk largely about the monoclonal antibodies because of the fact that they're probably the most important group that's come available now. And you can see that most, if not all of these have now been approved. I'll talk a little bit about that. But also to make you a little bit more excited, I'm going to talk about some of the other things which are coming on behind that. And so we're probably going to see about 6 to 7 new therapies, all designed for this treatment of migraine, coming through in the next probably 2 years. And I'm just going to mention Botox at the bottom, and I'm also going to draw everyone's attention to sumatriptan injection. I'm not going to talk much about that. Any of you who have the sumatriptan injection might know it comes in a 6 milligram dosing. Actually, now there's a 3 milligram dosing. So if you have side effects with the sumatriptan 6 milligram dosing, trying the 3 milligram injection might give you the same benefit, but with lesser side effects. So we're going to talk about CGRP, and why is that important? Well, actually, it's important because it's significantly involved in pain and the pathophysiology of migraine. And I'm sure all of you know why migraine is important, but actually this puts it into context. And the reason I give some of the data about how frequent migraine is, 10 million sufferers in the UK, 1 in 5 women in their lifetime, 1 in 12 men in their lifetime, and at least 6% of children have this condition, is that the fact that it's so common has provided NICE with real problems in terms of why sometimes they've refused these things, because the funding of new treatments, if expensive, has a major cost burden. I'm going to just highlight to all of you, I hope I'm not telling you things you already know, is that we think of migraine as a lifelong condition in some respects, and actually as doctors we have this slightly unnatural classification syndrome, whereas if you have headache less than about 15 days a month, we call it episodic. And if you have it more than 15 days a month, headache more than 15 days a month, predominantly migraine, and you've had it like that for 3 months, we call it chronic migraine. And the only reason that's important is because of the fact that the people who approve drugs look at it in those terms and when they're licensing drugs. Whereas, as I'm sure all sufferers and doctors see, we see people who ebb and flow between 12 and 18 days of migraine. You've just got troublesome migraine. Doesn't matter what we call it. So first of all, about calcitonin gene-related peptide. So calcitonin gene-related peptide was discovered about 20 years ago by one of my mentors and colleagues, Professor Goldsby, who's also a trustee for the Migraine Trust. And what it is it's a protein, which is really important to the nervous system. It's found all over the nervous system. It's also found in your gut. And it's got receptors on the blood vessels. It's got receptors in part of your brain, which is been identified as being involved in migraine activation. And it's also involved in some of the pathways which go up to the brain in terms of stimulating other systems in terms of nausea sensitivities. So we've got a protein and we've got receptors which are very relevant. The importance of that is it's allowed us to identify why this might be a useful protein to act against. If you infuse CGRP into somebody with migraine, you induce a migraine within 24 hours. And over the last 20 years, by doing that and finding drugs which block CGRP, we've identified that by blocking CGRP, you can abort migraine attacks. There are currently now 3 UK licensed anti-CGRP monoclonal antibodies. And these are the names, you might know them for their trade names: Aimovig, which has been all over the news about 2 years ago, Ajovy or fremanezumab, and Emgality or galcanezumab. They do differ a little bit. They don't differ in terms of how they're given. They're all given as an injection. Most of them given monthly, 2 of them given monthly, 1 given 4 weekly. 3 of them are given by subcutaneous injection in the same way as you inject a sumatriptan. And 1 of them is given an infusion. And I'm not going to talk much about the infusion because that's not yet available in the UK. If you want to buy them, and some people do want to buy them because they can't get them on the NHS, actually the cost price is about £386 a month. But it's a bit like selling mobile phones with the drug companies. Because there's 3 drug companies, they've all put in kind of deals, for want of a better word, and have tried to kind of undercut each other. And this is where NICE has really kind of come to the fore, because although the drug is costing £386 per month, NICE has got that price down to a lot less than that. And we probably got the cheapest anti-CGRP monoclonal antibodies in Europe being provided in the UK because of NICE. All of these drugs can be provided by a home care scheme. So if they're prescribed by your doctor, there are schemes where actually it can be delivered to you and you can be taught how to use the injection at home. In COVID times, that's become increasingly important. What's the differences between them? Well, 3 of them affect what's called the protein when it's circulating around in the blood and other places. And that's fremanezumab, galcanezumab, and eptinezumab. Whereas Aimovig or Renamab actually blocks where it acts on the receptor. So that's as if it closes the door, and that's as if it talks to the molecule when it's circulating around. We thought before the studies there might be differences in the treatment response to these, but actually the site of action doesn't appear to make a big difference. It might make a difference to side effects. So can we get these drugs now? And can we have them on the NHS? Well, we can have them on the NHS, but rollout is fairly slow. All 3 of these drugs have been NICE approved. The first one, Ajovy or fremanezumab, in June 2020. The second, galcanezumab, in November 2020. And Aimovig or Renamab, which was originally turned down in December 2019, pre-COVID, has just been approved, and it's due to be published on January the 27th unless somebody appeals against the positive approval. So that means all 3 of these drugs in 2021 should be available for migraine, but there are some caveats. And this is a bit of a busy slide, and I know this is being recorded, so possibly we could have a deal with this in the questions, or you can look at this at your leisure. And you can see here, I've talked about episodic migraine and chronic migraine. And this is really important because some of them are approved for one indication and some are not. All of them have evidence in chronic migraine and episodic migraine. So this is about the regulation and the cost effectiveness of these drugs in the UK, not the effectiveness. Ajovy or fremanezumab can only currently be prescribed for chronic migraine in the UK. Galcanezumab and Renamab can be prescribed for any migraine in the UK as long as you meet criteria, and Botox, for those of you who might have had those before, can only be prescribed for chronic migraine on the NHS in the UK. In order to be eligible for this treatment in the United Kingdom by the NHS, and actually this is largely relating to England, because Scotland have approved these drugs previously, you have to have had exposure to at least 3 different preventatives. They can be oral, they can be injectable like Botox, but they have to be evidence-based preventatives. It doesn't mean homeopathic medications or drugs which are not on the list provided by NICE. As you can see, there are different injection protocols, and all of these drugs will be stopped if people don't have an adequate treatment response within 12 weeks. So what's likely to happen is people are going to be offered these drugs. There'll be an assessment within about 12 weeks. In our service, it's going to be about 10 weeks. And if you haven't had an adequate frequency reduction in your migraine, the drug will no longer be continued. And if you have chronic migraine, the general treatment response, you should have seen a 30% or greater improvement in your migraine frequency. And if you have episodic migraine, we're looking to see a 50% or greater improvement in migraine. And we can talk about whether that's a useful thing or not as we go through the questions. But the sting in the tail with these positive approvals is what the recommendations don't say in the top line data. It's fantastic news that these new drugs have been approved because they're effective. But actually, it may be important as to which one you have first if you want to have access to the others. Because the first approval for fremanezumab for chronic migraine didn't put any restrictions on having a second monoclonal antibody if you failed to respond in that 3-month period. But the more recent approvals for galcanezumab and erenumab, or Emgality and Aimovig, stated that if you failed to respond according to the criteria set within the first 3 months, you shouldn't be offered a second drug to see if it was any better. Now, in this current financial climate, some people will jump on that and say, well, you've had one, you can't have another. And we're currently appealing against that because of the fact there is data from the United States to say that if one person fails to respond to their first monoclonal antibody, possibly 30% or more may respond to a different one. And that's because of the mechanism of action. So using that data, some people might say, we're going to start you on fremanezumab first for chronic migraine if you have chronic migraine, because that hasn't got any caveat for you having a second drug. Whereas actually, if you start galcanezumab and in the current plans for erenumab, you may not be able to have another one after that if you don't respond. And I'm happy to take questions on that. So what kind of response can you expect from these new therapies? Well, actually, the Migraine Trust has put a survey out before and said that what do migraine sufferers want? And migraine sufferers want cure, which is what we all want. But actually, we're not at that stage with these drugs. Whilst these drugs are very well tolerated and pretty effective, they're not cures. In some people, there will be no response, and in some people there'll be super responders, and I'll show you some of those. So it's really useful when if you're thinking about managing your migraine with these drugs that we have some targets. What are the reduction targets? You know, we certainly want to see a 30% reduction in your migraine, or is it a 30% reduction in your wipeout days? We want there to be a treatment response which is sustained. We don't want it to work for 1 or 2 months and then not work, because that's more likely to be a placebo response. In my clinical practice, I'm seeing triptan responsiveness improved. I've seen some people show little reduction in their frequency, but suddenly their triptans are fantastically effective. And most important, any treatment for migraine has to improve quality of life, to improve your ability to be able to do the things you want to do, have those symptoms hopefully reviewed and resolved, and be able to do the things with your family, friends, and workplace as and when you want. And I'm going to show you some busy slides, some data, so don't get too caught up about the data. And this is data from the studies on episodic migraine. And probably what it's showing you is that these are the people's, the blue is the baseline headache frequencies when they went into the trial. And you can see that about 8 to 9 days a month when they went into these trials. They had 3 months of therapy. And after 3 months of therapy, the mean, and that means the average reduction in migraine frequency in people taking these drugs at varying dosages was about halving of their frequency. Some people did more, some people did less, but you can see these were not cure drugs. But actually having a halving of your frequency was significant for a large number of these people. Half as many drugs, half as many days having to go to bed. And this is the data for the chronic migraine. Again, a lot of data, and I'm not going to get too caught up with the data. These are now much higher frequency baselines. Those are people who are having almost 15 to 20 days a month of migraine plus other headaches. And you can see here the frequency reduction is slightly less. That's why the bar for reducing chronic migraine is a bit less. But we're seeing in general about 4 to 5 day reduction in a significant proportion. Some people a lot more, some people much less. So again, these are not cure drugs, but they are drugs which make a difference. So is there a better way to look at the treatment response? So one of the ways to look at the treatment response is how many will have a halving of their frequency, and that's called a 50% responder rate. And again, I don't get caught up with the graphs, but in general, in people who have episodic migraine, so migraine less than about 14 days a month, we were seeing that about 50% in all the groups, you've got to think about the placebo group, about 50% of people have a halving of their migraine frequency. So if given one of these drugs, there's about a 1 in 2 chance that your migraine frequency will halve on a variable basis for the first 3 to 4 months in episodic migraine. In chronic migraine, that number is a bit less. So again, higher frequency patients, people who are having migraine about half to 2/3 of the month, and there's about a 40% chance. So that means pretty much 2 in every 5 people will have a halving of their migraine frequency when prescribed these drugs. But those studies looked at people who had only had 1 or 2 preventatives. So those are the people who might go to their GP and be seen in the community more so. But the GPs aren't going to be prescribing these drugs because of their high cost. So there are some other studies which looked at people who are failing on 3 and 4 medications, and they're called the Liberty study, the Focus study, and the Conquer study. And they are people who have probably had the preventatives you've all heard of: topiramate, amitriptyline, propranolol, sometimes Botox. And what they showed was that people who are less responsive to treatments, having tried at least 3 or having major side effects with treatments, also had beneficial effects from these drugs. And you can see from the graphs again, and I've looked at 50% responder rates. So these are people, 1 in 3 people approximately, having had at least 4 drugs, 3 to 4 drugs, has a 50% reduction in their frequency. So these drugs are added value in terms of new treatments. What was fantastic, was actually to see that some people, 12%, so that's probably about 1 in 10, were seeing a significant reduction in their migraine frequency, almost a 75% reduction. And in some people, if you were really 1 in 20 was having a 100% reduction, cure of their migraine for up to 6 months whilst on these therapies. But bearing in mind, these were episodic and chronic. So in the chronic phase, there was less of that. And that was mirrored with all 3 drugs. And you can see the data here. I'm not going to show you, but you can see the trend. Significant numbers having a halving of their frequency, having failed on at least 3 to 4 drugs. And that is what convinced NICE to approve these drugs. So what happens in the real world? Those are clinical trials. Those are people who've been chosen to go into clinical trials. Well, actually, I'm very thankful to my colleagues, Dr. Giorgio Lambrou and their team at Guy's and St. Thomas's, who did some fantastic rollout of erenumab, pretty much just before and through the COVID-19 pandemic. And they've looked at people who had been through their service, who had failed on at least 8 prior oral preventative therapies. At least 9 out of 10 in the people who received erenumab or Aimovig, who went there, had cranial Botox treatment. So they'd been through most, if not all, therapies. And what was wonderful to see is that when you added these new anti-CGRP drugs into their treatment regime instead of what they previously had, you had at least 50% response, people having a 1/3 less migraines, and actually about 1 in 3, having failed on that many drugs before, had a 50% reduction in their migraine frequency. And these are people who are having migraine 2/3 of the month or more. So significant benefits, significant improvement in something called their HIT6, which is a migraine impact assessment score. A lot of these people were overusing medications, so actually that didn't make as much difference as it does with some of the oral drugs. And although there were side effects, none of those were life-threatening or severe. 1 in 5 had constipation. That's one of the things that can occur with Aimovig. And this data is probably what convinced NICE to change their mind from refusing approval of Aimovig in December 2019 to just about approving its prescription within an NHS framework in January 2021. So it shows the importance of data research and all the hard work that those people do at that unit and the other units, and also the importance of keeping your diaries. So do these drugs work for long periods of time? And this is again, I'm not going to bore you with data too much, but this is to show you that in people with chronic migraine and in people with episodic migraine who are treated for a year, and these are two different drugs. You know, this one here is erenumab or Aimovig. This one here is galcanezumab or Emgality. You see that if you have a treatment response, this treatment response improves over time the longer you take it. And that's been shown in a number of studies now. And we've actually got some studies up to 5 years with Aimovig or erenumab in the United States, which is showing sustained benefit. Again, not cure, but making life more manageable without significant side effects. And this is some of the data in terms of high frequency reduction in migraine, and again quite a lot of data. But you can see here patients receiving galcanezumab or erenumab for episodic or chronic migraine. After about 12 months, 1 in 5 in the patients with episodic migraine and about 1 in 20 of the patients with chronic migraine had almost complete remission of their migraine, having been on this therapy beforehand. One can always argue whether that's just the migraine resolving, as it does from time to time, but this occurred in the context of having sequential measures. But what's really encouraging is that at least half of people with chronic migraine, so high frequency disabling migraine, and at least 3/4 with episodic migraine continue to have a beneficial effect from this treatment over at least 12 months if you continue on the therapy. And compared to the prior oral therapies, the chances of people remaining on this drug are good. This is a slightly different data, and this looked at people who have a 50% reduction, whether they maintain that 50% reduction, and not everybody does. This looks at what's called a sustained treatment outcome. That means that you have a 50% reduction when you get to your 3 months phase, and you continue to have that 50% reduction. And it's about 1 in 3 who maintain that response. Side effects. So everything sounds quite good so far, but what are the side effects? Well, the fantastic thing from the studies was there were no serious adverse events. Certainly because we're injecting, there's sometimes a little bit of injection site pain, and sometimes you can have a bit of hypersensitivity. And if you go onto the American social media, they've made a big deal out of this, but actually it's not a big deal in clinical practice. There's a bit of a throat, upper respiratory tract-like sensation. And of those of you who take triptans, you often find that people get this funny feeling in their mouths and in their throat, a tightness. And I think this is probably an anti-CGRP side effect. I don't think we know exactly what does it. Constipation has certainly been noted in the United States and by the London group, and very, very recently the possibilities of worsening hypertension has been suggested. So now at our centre we're doing blood pressure measurement before you start therapy, just as part of the assessment process. But what's really important is there are no problems with hormones, there's no immunological reactions, there's no cardiovascular problems or significant side effects that have been so far seen with these drugs. And people adhere to this. They remain on this drug because they don't have the side effects. And if you compare that to the old drugs, and I will compare it in a minute, you will see that those side effects are what often stop people taking the oral medications, as well as lack of effectiveness. So I ask myself the question whenever I have a new drug coming along, particularly a high-cost new drug. You know, this is, some people would argue £386 a month is a lot of money. Well, if you have to pay for it, it is. But actually, in terms of the amount of cost that lost productivity and workplace loss and family time loss, it's probably not that expensive. But these drugs are much more pathophysiologically relevant. They were designed for migraine. They were identified as being affecting a relevant protein in migraine, and they weren't a drug used for another condition repurposed to be used in migraine. The efficacy has been shown beyond doubt. Not a cure, but certainly much more effective than placebo. And NICE, who are very robust at look at the evidence, state that they're all clinically effective. The onset of action, usually in most, is within the first month. Certainly, you'd expect something by the second month, but actually we've managed to get 3 months of therapy to make sure people get a good trial of therapy. Interestingly, the London group found that some people needed more than 3 months and up to 6 months, but actually we're left with only being able to provide it for 3 months within NHS. Tolerability, much better. Sustained effect, at least a third have a sustained effect, and it's probably more. Adherence, well, so far from the trials, we're showing that adherence is really good, but actually time will tell. People taking these drugs and deciding to stay on it or come off it will be the final arbiter. People vote with their feet. Safety, so far, yes, but it's early days because this has only recently come out. And it's not clear which MAB is right for which person. That is unclear. And that might become clear over time. And is it important if you fail on one which affects the protein to try the other one which affects the receptor? And the long-term outcomes and combination therapy is already being assessed. But are we talking about the emperor's new clothes, the hype of a new drug? We really don't know yet about what long-term anti-CGRP blockage may do. There are some potential risks because there are receptors elsewhere. And these drugs are large molecules, so they don't get into the brain. They work peripherally. So if they got into the brain, would they be even more effective? And that brings me to other drugs which are coming along. Now, these are not yet available, but you will start to see these in clinical trials and possibly being assessed for usage in the next short period. And these drugs also work on this molecule called calcitonin gene-related peptide, on this neuropeptide, but they're small molecules. That means they do get into the brain sites where we know this CGRP receptor is. So theoretically, they may be more effective. They are oral. Atogepant is the one which is the one being used in preventative treatment trials. And there are some treatments looking at acute migraine. And behind all of the CGRP story is the next neuropeptide. So things are looking really bright in terms of neurosciences research in migraine, is because we have another protein called PACAP38, which again, if you infuse into migraine sufferers, will induce a migraine within 24 hours, as did CGRP. And we're now in a situation where we're starting to block that protein in clinical trials to see if it is as effective, more effective, or works differently to these drugs that have recently been licensed. So what about these oral small molecule CGRP receptor antagonists? Well, they've got funny names. You've got abrogepant, which is produced by the same people who give you Botox, and that's been shown to reduce acute migraine. And these are being used for acute attacks in people who don't respond to triptans or are intolerant of triptans. And we're finding from the studies, the early studies, that similar to triptans, they can give about a 20% headache freedom within 2 hours of taking them. And they also affect some other symptoms. The one thing which may be a concern to some people is they make you a bit somnolent or tired with the higher dosage. There's a second drug called rimegepant, and that's got similar data. And I'm not going to go through the data. And both of those drugs are now licensed and available in the United States. And I would assume they will eventually be applying for licenses in Europe and the United Kingdom. And finally, the last thing I'm going to leave you with is a new class of acute medications called ditans. And the drug called lasmitidine has just NICE have just announced that they are going to do an assessment of its clinical effectiveness and cost effectiveness for use in acute migraine in the United Kingdom. They just sent the scoping letter out yesterday. And lasmitamine again is approved in the United States for the treatment of acute migraine. It shares some actions with sumatriptan, but the thing about it is it doesn't work on blood vessels. If any of you are taking triptans, you might know that if you have had a heart attack, or if you have uncontrolled high blood pressure, or if you've had a stroke or TIA, you can't have triptans. They're contraindicated. So there are people who may have had strokes, or people who may have had a heart attack in the past who have migraine, who now have lost their acute abortive therapy if they were using triptans. Whereas this specifically works on receptors in the brain, not on the blood vessels. It's very effective. It can be used similarly to the triptans. The one side effect that may be a problem is it induces a bit of dizziness. And we've just heard from Riabola that migraine-related dizziness and vestibular migraine can be a problem. So therefore, there are certainly going to be some issues in terms of the tolerability versus the effectiveness of lasmitamine when it becomes available in the United Kingdom, and if it does. It's already available in the United States, as are several of these drugs. So hopefully I've given you a little bit of a glimpse into some of the scientific data which shows that migraine trust supported research does make a difference. It brings us new therapies. It gives us new opportunities. It tries to seek finding a drug and treatment plan which will improve migraine frequency, severity, and achieve that ultimate aim of trying to make migraine a manageable condition, and possibly, not in my lifetime, possibly a cure. The future of migraine care in my mind is much brighter than it was when I started doing this about 16 to 20 years ago. And I'd like to thank the Migraine Trust for giving me the opportunity to share some of that information today. And I'm happy to answer any questions.